Good day, everyone. I would like to welcome you to this episode of the System Podcast. And this is the Obstetrics and Gynecology Revision Series. So today we'll be talking about the management of perinatal infection, specifically management of HIV in pregnancy. How do you manage it? And we have a VNIAC or a caveat that we'll use. Now, we have a 30 years old para 2 plus 0 who is HIV positive and on highly active antiretroviral therapy that presented to the antenatal clinic for booking at 16 weeks of gestation. Now, they want us to discuss the management. So there's a stepwise process to management of anything in medicine. And I would follow that, but we'll be focusing on the question because the question is trying to test our ability to manage a woman who has HIV and she's pregnant. So now let's go into the introduction. Now, HIV in pregnancy is something which is kind of like, which is not too good to have because the management will be focusing on trying to stop the woman from having the complication of either the HIV itself or the side effects of the drug because she's already on highly active antiretroviral therapy, and also will try to stop the child from having or contacting the HIV, that is mother to child transmission, that's MTCT. Now the next thing, the line of management is initial assessment and booking. So you have to know that when a HIV positive woman on highly active antiretroviral therapy presents to the antenatal clinic at 16 weeks, the initial assessment is very crucial, and the goals are to ensure maternal health, reduce the risk of mother to child transmission of HIV, and address any complications related to both pregnancy and HIV, as we have said. So the first thing you have to do in this management under the initial assessment and booking is to take complete medical history in detail. For every antenatal first visit, definitely we have to do the complete history, which is very, very important. So, but here we will not go step by step talking about each step of the antenatal history because as the question is focused, or let me say the discussion today is focused. So what we will want to dwell in the detailed history that we're expected to take is to try to confirm her HIV diagnosis when it was confirmed, where it was confirmed. So we have to be sure that we are dealing with HIV, and her current regimen of the highly active antiretroviral therapy is very important, and her compliance and adherence to the drug. Any side effects, maybe recent or past one, and her obstetrics history is very, very important. In her obstetric history, we would like to review her previous pregnancies, any complications and birth outcomes. And her current pregnancy, we would like to confirm the gestational age, which in our VNIAC is 16 weeks of gestation. We would like to assess the fetal well-being. How is the fetal doing at that time? How is the fetus doing at that time? And screen for pregnancy-related conditions. So it's important to screen for all those other pregnancy-related conditions. So the next thing, we would like to also do the physical examination. Like to do the since it's an obstetric case, we'd like to do the obstetrics examination, and next we also like to do some other examination if it calls for, based on the patient. But with regards to our VNIAC, there's no much things or much detail or much thing that we'll be able to pick up from the examination, as even the pregnancy, we cannot be able to use this infusofundal high to assess pregnancy at 6-week gestation because it has to reach at least 20-week gestation before we can use the SFH to know that. So the next thing in the initial assessment and booking, we would want to do the laboratory investigation. Laboratory investigations are very important. We are dealing with a woman who is a known HIV patient. So here, the first thing is we would like to assess the viral load, HIV viral load, and the CD4 count. This is very critical. because we want to know the effectiveness of the HAART, that's the highly active antiretroviral therapy that she has been on, and the immune status. And ideally, the viral load should be undetectable to minimize the risk of MTCT, which is mother-to-child transmission of HIV. And we would like to also check the full blood count and the LFT to monitor the side effects of the HAART that she was previously on. And we also like to screen for co-infections. There are some co-infections that can also be that are mostly together with HIV. These are things like syphilis, hepatitis B and C, TB, and some other sexually transmitted infections like chlamydia, so gonorrhea too. So we would like to check for those. And next is the routine prenatal labs, such as the blood type, blood grouping, very important in any first antenatal visit. And antibody screening, we have to do that. And the urine analysis is very important. And part of the examination, some things we have not talked about, like the weight, the height, the BMI, all those things are important for routine antenatal visit. But for here, since we have a focus, that is why we are kind of like skipping those things. So we will have an episode which will talk about the routine antenatal visit, what is expected to be done and how it should be done. So the next thing here, we'll be talking about the management plan. So for the management plan, since the woman is already on a highly active antiretroviral therapy, we'll just have to continue the antiretroviral therapy and make sure she adheres to it. And the regimen have to be reviewed to ensure it's safe and effective during pregnancy. If the viral load is detectable, we'll consider resistance testing and potential regimen adjustment. So that's for the first part of the management plan. Then the monitoring. With regards to the management plan, we have to monitor regular follow-ups to monitor viral load, CD4 count, and any highly active antiretroviral therapy related side effects. Typically, viral load testing is done every 1 to 2 months during the pregnancy. Then the preventive measures, we have to administer some prophylactic treatments as needed, such as cotrimoxazole for opportunistic infections. Since we know she's immunosuppressed and she is susceptible to infections, if the CD4 count is low, and vaccinations like influenza and tetanus vaccines should be given. Next, nutritional support is very, very important. We ensure she receives adequate nutrition and and prenatal vitamins, including folic acid and iron supplementation, which is also part of the routine antenatal supplements that are given. And next is counseling and education. We have to provide counseling on the importance of the HAART, that's highly active antiretroviral therapy, adherence, and safe breastfeeding practices, and the benefit of delivering in a hospital to reduce maternal to child transmission risk. So the next part of the management that we have to focus on is the delivery planning. So the delivery planning, we have to discuss and plan for delivery, ideally in a facility with expertise in managing HIV positive pregnancies. So the first thing is the mode of delivery. If the viral load is undetectable, vaginal delivery is often recommended. If the viral load is if the viral load is detectable near term, a cesarean section is very important, is needed to reduce the risk of maternal to child transmission or mother to child transmission. And for the intrapartum management, we administer intravenous zidovudine during labor if indicated, especially if the viral load is not adequately suppressed. So for the postpartum care involves two things. We have the maternal health and the infant care. So the maternal health will continue the highly active antiretroviral therapy postpartum and monitor for any complications. And for the infant care, We immediately administer antiretroviral prophylaxis to the newborn and conduct early HIV testing at birth. Then 6 weeks, and as per local guidelines. So that's kind of like the overview and how you are expected to approach a question with regards to the management of a HIV positive pregnant woman. And in conclusion, managing a pregnant woman with HIV requires a multidisciplinary approach to ensure the best outcomes for both mother and baby. Adherence to the highly active antiretroviral therapy, regular monitoring, and comprehensive care throughout pregnancy and postpartum are key to minimizing risk. So, thank you for tuning into the System Podcast. If you found this episode helpful, please subscribe and share it with others who might benefit. Stay informed and take care. Thank you.